Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Welcome to today's briefing on the future of telehealth and its impact on primary care. We've all seen the explosion in the use of telehealth, but its future is quite uncertain. Congress has still not passed a permanent law extending the pandemic's telehealth payment policies. We've seen growth in telehealth use and some tapering off, but it seems now to have stabilized. For many, telehealth, in addition, of course, to the response to the COVID pandemic, is an opportunity to address access barriers and access limitations. We've seen its use in the primary care context, but there are also limitations to what can be conducted using telehealth and concerns about the quality of the visit and its appeal to both clinicians and to patients. So we're very excited today to hold a briefing focused on the future of telehealth with a particular focus on its effects in the primary care context. Today's conversation is part of our broader series on the practice of medicine, which is supported by the Physicians Foundation. We're grateful to the Physicians Foundation for their support of all of the work we do in this area and today's briefing event. For those of you watching live, we do have a little bit of time in the two panels that we have for questions from the audience. If you have questions that would be of general interest, please submit them using the Q&A tab at the bottom of the screen. I'll do my best to weave them in to the conversation, but I hope you'll forgive me if I don't get to your specific question. It's now my pleasure to introduce to you Gary Price, who is the president of the Physicians Foundation. Dr. Price is a board-certified plastic surgeon. He's held leadership positions in local and national and state medical associations. We've had the pleasure of working with Dr. Price in our longstanding relationship with the Physicians Foundation. And so, Dr. Price, I turn it over to you for some opening remarks.
Thank you, Alan. It's a pleasure to introduce this webinar about the future of telehealth and its impact on primary care. The Physicians Foundation is dedicated to empowering physicians to lead in the delivery of high-quality, cost-efficient healthcare. And the state of primary care and the future of telehealth are critical to that mission. Our work is committed to bettering the physician practice environment and creating a system that is sustainable and healthy for both physicians and their patients through research, education, and innovative grant making. Currently, the state of primary care in the United States is facing significant challenges, exacerbated by a combination of workforce shortages, underinvestment, and evolving healthcare delivery models. There is an urgent need for investment and expansion in primary care. Yet, the primary care workforce is shrinking and cannot meet patient demand, particularly for those in vulnerable communities. Telehealth has emerged as a pivotal component in addressing some of these challenges, cementing its role during the COVID-19 pandemic when in-person visits were limited. It offers the potential to expand access to care, especially for populations with limited transportation options, work-related time constraints, and those living in rural areas without physical access to timely care. While telehealth will likely prove to be an invaluable resource of enormous value, that value is yet to be tapped. Perhaps its true potential can only occur when it is fully and properly integrated into today's primary care reality and tied to tomorrow's primary care aspirations. Despite its benefits, telehealth also presents challenges that impact the primary care landscape. The integration of technology into healthcare delivery has added burdens to primary care practices. While telehealth can provide episodic care, it may contribute to the fragmentation of that care, if not part of a continuous patient-clinician relationship. The pandemic has given us glimpses of the potential and pitfalls of telehealth technology. We know that it can be quickly and efficiently adopted, taking only 5 minutes to add to my specialty practice. The usefulness and adoption of telehealth appears to vary widely by specialty, be usually welcomed by patients, and heavily dependent on reimbursement policies with many, as yet incompletely studied impacts on cost, care, and consequences. To completely address many of the questions around telehealth, systemic reforms are also necessary. policy solutions, including diversifying the primary care workforce, increasing investment in community-based training programs, and redesigning payment models to support high-quality primary care are critical and overdue. These measures should aim to strengthen the primary care infrastructure and ensure that all individuals have access to comprehensive and coordinated care. Primary care is the gateway to better, more widely accessible, and affordable healthcare for millions, and plays a critical role in improving the lives of communities and supporting our healthcare system. Telehealth offers promising opportunities to enhance access to primary care. The question now is, how can telehealth best be integrated thoughtfully into our healthcare system? Our discussion today will offer perspectives on these questions from experts based on points of view from the latest research. The Physicians Foundation is tremendously pleased to sponsor what will be an interesting and stimulating discussion, which the editors and staff of Health Affairs have organized. I would like to thank them, our presenters, and thank you, the audience, for joining us today. Alan?
Dr. Price, thank you so much for the opening and for your support of our work in this area. It's now my pleasure to introduce our panelists. At Health Affairs, we ground everything we do in evidence, and I'm pleased to have 4 authors of papers that we've published as part of the Practice of Medicine series. They're going to present not just their papers, but some broader commentary as they choose on the topic that we're discussing today. I'll introduce them all quickly now, and they'll follow in sequence. We'll begin with Jillian Steele-Fisher at the Harvard T.H. Chan School of Public Health. We'll then go to Carter Nakamoto at Stanford University, turning then to Nathan Pawley at Manat Health Strategies, and finishing up this panel with Jiani Yu from Cornell University. Those will be the presentations. Will be followed by a brief period for discussion, and then we'll go to our second panel. Let's kick off the evidence-based discussion with Dr. Jillian Steele-Fisher.
Thank you all so much. I hope you can hear me. I'm Jillian Steele-Fisher, and I'm so delighted to be with you all today. Thank you so much for having me. And I'm delighted to kick this conversation off because I'm talking about perspective of the people most impacted by telemedicine in this context. And that is both the patients and the physicians who are receiving care and giving care in this context. As was mentioned, I'm Jillian Steele-Fisher, and I run the Harvard Opinion Research Program. And so no surprise, what I'm interested in the way that we think about health policy is bringing the perspectives of the people most affected to the table. And so I hope that that's how we can lay out this conversation to begin. So let's start just by thinking like, well, why do we do this study? What do we actually already know about patient and physician views about telemedicine? And I think that what you probably sort of know generally and what you've seen is that a number of studies suggested that telemedicine was important to access in COVID for sure. And we knew that was the case. But what people thought of it was that it was good, right? People were satisfied. And there were a number of studies that said, yeah, people liked it. But as a survey methodologist, I wanted to know more. I wanted to know, well, does it like really mean like what does satisfied mean? Like, would you recommend it? What does that really mean for that sort of quality of care, for what we think about sort of integrating care into telemedicine into care? And so I felt like it was, too, or our team really felt it was too broadly defined. We didn't have national data. We didn't ask people to compare sort of what was done virtually to in person. We didn't understand quality in this context. And so we set out to develop a study that would help give insights into those dimensions. And so what we did was we did a dual nationally representative survey looking at PCPs who provided telemedicine visits during COVID, and we looked at the patients who had primary care telemedicine visits during COVID on the other side. And so we did these 2 studies together and tried to think about the data and what that could tell us about their experiences and what it might mean for the way we approach policy. So we started out by a question that looked a lot like the questions that we'd seen in other surveys. So how well did your video-based visit go? And not surprisingly, we saw results that looked a lot similar to what we saw elsewhere. As you can see in this, we asked people, how well did the video-based visit go? And physicians, 41% said very well, another 49% somewhat well. We have 90% saying went well, thumbs up. Patients, pretty much the same. When we dig in a little bit more, that's where it gets interesting and different. So we asked, for example, them to compare the quality of the care they could provide or receive in a video visit compared to an in-person visit. And what you see in these data is that very few people thought that telemedicine was better, either physicians or patients. If we sort of sum up like much better, a little better, about the same, like this is what we sort of hope for at least, only a third of physicians are in that bucket and only 2/3 of patients, which leaves about 60% of physicians saying it was worse, right? So we looked at other dimensions of quality and we see somewhat similar results in terms of rapport. Doesn't get great rave reviews, and neither in sort of time spent. These are the dimensions that we thought might be enhanced in the telemedicine context. We really didn't see much. So we asked sort of the penultimate question, which is like, well, do you want to do this again? Like, do you want to keep doing this? And what we see here, when we asked about preference for future visits, is that the vast majority of physicians said they would prefer in future to have all or most of their visits in person, and the majority of patients agreed. 2/3 and 80%, so 4 to 5. So pretty striking findings, and a kind of a contrast to that sort of data that we'd seen elsewhere, which is like, thumbs up. This sort of gives us pause, and we try to dig into why that might be. We could see in other data that I won't present here for sake of time, but that it seemed to go better in some areas, like in mental health provision by primary care providers, as opposed to maintain chronic illness or preventive care, but it still really wasn't clear. So we tried to identify some of the predictors. I'll be honest, the results weren't exactly what we thought. It turns out that quality of care, which we figured would be the big answer, right? It turns out that wasn't really a predictor of whether or not physicians wanted to go back to in-person or not in future. It didn't come up in the same way. If you thought that, telemedicine did a great job in terms of time or rapport, yes, you sort of were more likely to want to stick to that and less likely to want to go to in-person again. But those numbers are pretty small. It wasn't really a huge issue. And you had to have a lot of technical challenges before you thought it was worthwhile to sort of, that would be the reason it would push you. When we looked at the demographics of our physicians and tried to understand that was also not particularly revealing in some ways. So we did see that if you were male, you were slightly less likely. If you were age didn't really seem to make a difference. If you were a Black physician or an Asian physician, you had slightly different results. But these were really small numbers again. That's a topic for another panel, but really an important one. But there wasn't a lot here going on. There was sort of something more fundamental in the way that physicians were providing care that we wanted to think about. When we tried to look at the patient side of things, we saw that actually quality did make a difference, which was insightful. We thought, okay, what's going on there in terms of rapport as well? And these other factors didn't make too much of a difference. And when we looked at their demographics, we saw that being older, certain racial ethnic minorities, and having less education were all predictors of wanting to be back in person and less likely to want telemedicine. So what do we think it means, right? Basically, telemedicine gets not as great a review as we were thinking. It's okay, it worked in a pinch, but it's not something we want to go forward. The reasons for physicians is that there's something more fundamental going on. Not just technology, perhaps the way they want to practice care, something about quality, but it's more than that as well. For patients, there is a perception of quality that's sort of there, but that's not the whole answer. And we see that there's sort of an ongoing digital divide that's going beyond just having access to telemedicine. So what do I think are the key implications from this? I think the first thing is if we really want video-based visits and telemedicine to persist, we need to think about some of the supports that we need to have in place. It's important for meeting patient needs. It's important for all the reasons that were outlined in the opening comments. But that means that some of the policies that were there to support telemedicine during COVID are actually almost more important now because there's not the same sort of business case for doing that in future. We also want to think about how we can improve quality in the context of telemedicine and video visits, think about the tools that can enhance that. And we also want to think about the ways that we can address not just getting people online in the first place, but even the persistence of some of those differentials in the digital divide, making patients more comfortable in the context of telemedicine as well. So with that, let me turn it over. Thank you so much.
Thank you for the presentation. We'll turn now to Carter Nakamoto.
Hello, everyone. I'm very excited and grateful to be invited to speak with everyone today. I am going to be speaking today on a paper that is out in Health Affairs, as I believe all of them are, that I did with these colleagues, David Cutler, Nancy Bilyeu, Laura Isher-Pines, and Atif Mehrotra, who is also here today. A brief bit of background. Telemedicine use spiked in 2020. This spike was facilitated by some regulatory waivers, some reimbursement changes, and in particular, this figure is showing us that Medicare's telemedicine use spiked, decreased a little bit afterwards, but remained at a level much higher than it was previously. However, this residual increased telemedicine use is facilitated by certain policies that are set to expire in December of 2024. So our goal was to use Medicare data claims to inform that policy discussion to quantify telemedicine's effect on utilization and quality. Great. So our analysis focused on health system level telemedicine use as the intervention, if you will. And we looked at 5.5 million continuously enrolled beneficiaries in Medicare fee-for-service, and we assigned them to these different health systems, which were in these different quartiles based on their use in 2019. But basically, what we're doing is we looked at assignment in 2019 to health systems. We looked at a treatment, if you will, an intervention which is health system telemedicine use in 2020. And we measured outcomes in 2021 and 2022, adjusted for what they were at baseline. So we're looking at differential changes for the high versus low telemedicine health systems from 2019 into 2021 and 2022. You'll want to think about this as meant to mimic a randomized controlled trial because patients generally stayed with the same health system throughout this time period. And because telemedicine use was so low at baseline, we took these patients assigned in 2019 and effectively randomly assigned them to either having access to a lot of telemedicine or not that much telemedicine based on this pseudo-random uptake of telemedicine at the health system level. And we focused on this type of analysis so that we could isolate the effect of telemedicine availability at this sort of regime health system level, as opposed to picking up, patient preferences or patient baseline health as driving differential telemedicine versus non-telemedicine effects we might be trying to measure. Can we go to the next slide, please? All right, so here are some of our baseline health system characteristics. This is going to be comparing the high versus low telemedicine health systems. Those are the rightmost and second to the rightmost columns. The most salient difference I want to point out here is that a much higher percentage of our high telemedicine health systems were academic systems. Next slide, please. Next, we're going to be looking at the patient characteristics of the high versus low telemedicine health system quartiles. The high telemedicine health systems were disproportionately non-white. They were much more likely to have patients living in the Northeast. And the patients at those health systems were much more likely to be metropolitan. So high telemedicine is going to be more non-white, more Northeastern, and more urban in this analysis. Thank you. Next page, please. All right. We are at our first figure, which is looking at telemedicine use by health system quartile throughout our study period. As you'll note, in 2019, our baseline health system telemedicine use is very low. We have these spikes in 2020. And although the magnitudes are not as high in subsequent years, we still see this stratification and this residually meaningful use of telemedicine across all of the health systems that we're looking at. Next slide, please. Next, we are going to be looking at outpatient visits per capita. What we see here is that there are small but meaningful and significant differences in the outpatient visits differentially by telemedicine use. So the high telemedicine health systems had slight increases in their visit counts relative to 2019, and those slight increases were larger at the high telemedicine health systems than they were for the lower telemedicine health systems. And this chart should give you some sense of the magnitude. It's around 2%. Next slide, please. This table is going to be summarizing the estimated differential changes in outcomes from 2019 through 2021 and 2022 by health system quartile, comparing the highest and lowest health system telemedicine quartiles. We talked about the visits and telemedicine visits already. We also looked at visit share with practice. You want to think of this as a continuity of care measure. How much of the care is with the primary practice? And we're seeing that there's a differential increase for the high telemedicine health systems. There's a differential decrease in ED visits for the high telemedicine health systems, and a differential increase in ED visits for the inpatient visits for the high telemedicine health systems, excuse me. Some people think of these things as there's, I think, room for interpretation with those two findings that may be contradictory or maybe conciliatory, depending on your interpretive framework. For drug adherence, this is going to be measures of PDC proportion of days covered for hypertension and diabetes. We're seeing differential increases in adherence for the high telemedicine health systems. When we look at preventative care, that's going to be mammograms, pap tests, those types of things, as well as imaging and testing services, laboratories, those types of things. We did not see any differential changes between the high and low telemedicine health systems. Finally, we looked at spending, and we found this modest 1.6% differential increase for the high telemedicine health systems. Next, we're looking briefly at differential changes by patient type. This is just looking at the visit outcome, but the high-level finding that you want to focus on here is that the less sick patients, those without diabetes, without hypertension, had larger differential visit increases at the high telemedicine health systems than the patients without these different forms of chronic illness. It's a triple difference. It's a little confusing, but basically this telemedicine impact that we measured previously is going to be larger among patients without these different chronic conditions. Next slide, please. And finally, we looked at social groups, and we saw sort of the opposite effect, that patients with more forms of social disadvantage had larger differential increases in visit counts. Next slide, please. I have to wrap up. So this is meant to highlight some limitations, although the text isn't showing up. We were, yes, it's limited because it's a certain point in time, clinical analysis. And this is another work that you might want to check out if you think this is interesting. Work done in another publication with remote patient monitoring. I'm over time. Thank you so much. Yes.
Okay. Thank you, Carter. And now we will turn next to Nate Polly from Manat. Over to you, Nate.
All right, thanks so much for the introduction. I'm Nate Polly with Manat Health Strategies, and really happy to be part of the panel today to give folks an overview of our recent analysis looking at trends in remote physiologic monitoring among Medicaid beneficiaries. We can go to the next slide. So just to start out with a little bit of background, remote physiologic monitoring, or RPM, is a service that facilitates the use of technologies like wearable devices and mobile applications to transmit health data, including things like heart rate, blood pressure, glucose levels, and blood oxygen levels directly from patients to providers. This type of asynchronous monitoring can be particularly beneficial to patients with complex medical problems and comorbidities like hypertension and diabetes, and can also be beneficial to people who have barriers to accessing in-person care. These services can allow providers to more closely monitor patient outcomes in real time, and can also save time in the office by allowing providers to focus on patient care rather than collecting physiologic data. In 2019, CMS adopted new procedure codes that could be used to bill RPM services, and we saw that other public and private payers soon followed suit, and that they also tended to expand coverage and reimbursement during the COVID-19 public health emergency. Some previous analyses looking at trends in RPM use among the commercial and Medicare populations have found that RPM use increased dramatically during the COVID-19 public health emergency, but previous analyses have not sought to look at use among Medicaid beneficiaries. Our study sought to fill that gap by using nationwide Medicaid claims and enrollment data from 2019 to 2021 via the TMSIS analytic files to look at trends in RPM use and characteristics of RPM recipients and providers. We think this is an important gap in the literature because we know that Medicaid beneficiaries are traditionally underserved and are disproportionately likely to experience many of the medical conditions that may be amenable to RPM use. This analysis is also timely because many states and payers are now reconsidering coverage and reimbursement options for RPM in the wake of the COVID-19 public health emergency. And this study presents just slightly more recent data on rates of RPM use and characteristics of RPM recipients that have been available for previous analyses. We can go to the next slide. Unfortunately, because of the brevity of the presentation today, we're not going to have time to do a deep dive into the methods, but would encourage folks who are interested in learning more to take a look at our paper. And if we can just go forward 2 slides, then we can jump right into some of the results and key findings. We can go one more. All right, thank you. This figure is showing the monthly rate of RPM use among Medicaid beneficiaries nationwide from January 2019 to December 2021. You can see here that the rate of RPM use was starting to trend upwards throughout 2019, but it really started increasing much more dramatically once the COVID-19 public health emergency started in 2020. You can also see here that in late 2021, rates of RPM use have begun to sort of plateau or stabilize. We can go to the next slide. This slide is highlighting the state-by-state variation in RPM use. And so here we're just looking at the annual rate of RPM use by state in 2021. One of the interesting findings here was that we observed dramatic variability in rates of RPM use at the state level. One of the secondary goals of our study was to look to see whether or not states that had documented RPM coverage policies in place had higher rates of use relative to other states. We found that only 34 states had documented coverage policies in place at the time of this analysis, but all states billed RPM claims in 2021 except for Vermont. So not having a documented coverage policy in place doesn't exactly stop providers from billing Medicaid agencies for these services. However, we did find that states that had documented coverage policies in place had 30% higher rates of RPM use relative to states that did not have documented policies in place. We can go to the next slide. This table is highlighting that RPM use is highly concentrated among a small number of providers. We ranked every Medicaid provider by the number of RPM claims they billed in 2021 and found that providers that were in the top 5 percentile in terms of RPM claim volume accounted for over 50% of RPM claims and nearly half of RPM recipients in 2021. We also looked at the most common types of providers billing RPM claims and found that internal medicine, general practice, and family practice physicians were the most likely to bill these services. We can go to the next slide. And finally, we looked at some of the characteristics of RPM recipients in 2021. We found that rates of RPM use were highest among older beneficiaries, which may be due to these beneficiaries being more likely to have conditions amenable to RPM use, and similarly saw higher rates among individuals that had comorbidities like diabetes and hypertension. We also saw higher rates of use among individuals living in metropolitan areas, which might reflect better access to internet infrastructure or more tech-savvy providers in these urban areas. We can go to the next slide. Just to wrap things up here with a few key takeaways. So again, we saw that rates of RPM use increased dramatically during the COVID-19 public health emergency, but they appeared to have stabilized in late 2021. This actually runs counter to some analyses examining different types of telehealth services. So actually, Carter began their presentation with a figure showing trends in telehealth use over time, showing that rates dropped off dramatically in 2021. Here we're finding that rates have stabilized in late 2021, and we'll need more recent data to see if that trend continues. We also found wide variability in RPM use by state. And while the study didn't seek to assess factors driving the state-level variation, we do think this is fertile ground for future research. Finally, we propose a number of levers that Medicaid agencies may consider to increase rates of RPM use where appropriate, including things like ensuring adequate coverage and reimbursement, and disseminating coverage policies to providers likely to bill these services, sharing technical resources with providers who may be interested in facilitating these services, and potentially working with other commercial payers in the state to encourage benefit alignment. At the same time, though, previous research has found mixed evidence regarding the efficacy of RPM services for some conditions. And RPM services have also been the subject of some Medicaid fraudulent billing schemes. So with that in mind, Medicaid agencies seeking to promote the use of these services should also try to strike a balance between promoting use for cost-effective indications while also mitigating the risks for fraud, waste, and abuse. And with that, my time is up. Thanks so much.
Thank you, Nate. And we'll now move to our final presentation in this first panel. Gianni, you.
Hello, thank you for the introduction. So today I will be talking about our paper, Telehealth Delivery Differs Significantly by Physician and Practice Characteristics. And I just want to first acknowledge my co-authors at Weill Cornell and funding from the Physicians Foundation who have all made this work possible. Next slide. Great. So we set out in this paper to ask, with many of the Medicare telehealth flexibilities expiring at the end of this year, who are the physicians, practices, and patients that continue to use telehealth at higher rates even 2 years after the onset of the pandemic, and therefore would be most affected by these policy changes. So using 2022 Medicare claims for a 100% sample of Medicare fee-for-service beneficiaries, we conducted a national comparison of telehealth rates across Medicare billing physicians and practices. Specifically, we studied the patterns of telehealth rates by physician characteristics. And we also studied how patient characteristics differed among those cared for by physicians delivering a higher versus a lower proportion of their visits via telehealth. So our hope is that, with this paper, we're making a contribution and that we're providing an updated assessment of telehealth provision after its rapid growth early on in 2020, which was then, of course, followed by a decline now that telehealth adoption has reached a steady state. Next page. So we found that in 2022, telehealth rates delivered by physicians nationally hovered at around 7% of all office evaluation and management visits. That's the most common type of office visit, typically done for things like routine checkups, managing chronic conditions, among other things. Overall, female physicians delivered relatively more telehealth than male physicians, and this disparity persisted across age categories. So as you can see, ranging from a 2 percentage point difference among younger physicians to a roughly 6 percentage point difference among older physicians. Please keep in mind that these results are purely descriptive and don't reflect any adjustments for things like physician specialty or other physician characteristics. Next slide. Great. So now when looking across physician specialty categories, we continue to see a higher uptake of telehealth among female compared to male physicians. We also saw substantial variation in telehealth uptake across specialties, so ranging from less than 1% in dermatology to 6 to 9% for male and female primary care physicians, and as you can see, 45 to 49% for male and female psychiatrists, respectively. Telehealth was also delivered for over 10% of visits for physicians in neurology, endocrinology, gastroenterology, and infectious diseases. Next slide. So in addition to looking at the average rate of telehealth delivery, we were also interested in examining the distribution of providers delivering higher versus lower rates of telehealth, as this may suggest larger shifts or changes in models of healthcare delivery from primarily in-person to primarily virtual. So here we show several deciles of telehealth provision from physicians who provide less than 10% of their visits via telehealth to physicians who provided over 90% of their visits via telehealth. What we found is that for psychiatrists, over a fifth delivered over 90% of their visits using telehealth. For PCPs, as you may expect, most, nearly 80%, delivered less than 10% of their visits through telehealth, and less than 1% delivered nearly all of their care virtually. Next. Great. So in addition to looking at the patterns of physicians delivering a high versus low share of telehealth visits overall, we also examined the characteristics of patients that were cared for by physicians delivering various levels of telehealth. So we found some interesting patterns. We found that primary care physicians providing a higher proportion of their telehealth visits, tended to see a higher percentage of patients that are dually eligible, a higher percentage of patients that are Black, patients that are Hispanic, and medically complex patients. Psychiatrists delivering relatively more telehealth, however, tended to care for lower percentages of patients that are Black and lower percentages of dually eligible and medically complex patients. Again, keep in mind that these results are purely descriptive and just serve as a jumping off point for future work, looking at differences in access and use of telehealth across patient populations. Next slide. So we also saw some differences in telehealth provision by specialty category across geographic regions. So for PCPs, as you can see on the left there, higher rates of telehealth provision were concentrated in the Northeast and Western regions of the US. And when we looked at state level telehealth provision by psychiatrists, there was a larger range of telehealth rates across states, so ranging from 23% to 61%. And we actually didn't see any clear regional patterns here for psychiatry. Next slide. And despite those differences in geographic uptake in that last slide of telehealth by specialty, we see that in all specialty categories, physicians in metropolitan and micropolitan areas delivered a higher share of visits via telehealth compared to those in rural areas. So for instance, as you can see, for primary care physicians, metropolitan areas, they provided around 8% of their visits via telehealth, whereas those in rural areas provided around 4%. And this disparity was around 5 percentage points for psychiatrists. So therefore, despite existing Medicare coverage of telehealth in rural areas, even prior to the pandemic, we didn't see rural telehealth uptake outpacing that of non-rural areas. Last slide. Great. So to summarize, our findings showed that in 2022, female physicians and physicians in non-rural practices delivered relatively higher proportions of their evaluation and management visits via telehealth. Telehealth visit provision also differed markedly by physician specialty, with the psychiatrists providing the highest rates of telehealth visits, followed by neurologists and other physicians, including endocrinologists. We also found that primary care physicians with greater telehealth provision tended to see more medically and socially complex patients, whereas for psychiatrists with greater telehealth provision, we tended to see a diverging pattern. So what we know from this paper is that even 2 years after the onset of the pandemic, telehealth still represents a sizable portion of healthcare services provided by primary care physicians and other physicians not specializing in behavioral or mental health. And so this is important for understanding how telehealth reimbursement might affect certain groups of physicians more significantly, as well as healthcare access for certain groups of patients. So I think that is all my time, and so I will end there. Thank you.
Thank you, Gianni, and thank you to all the panelists for your presentations. We just have a small amount of time for discussion. So I'm going to try to get through 2 questions that I will ask broadly of the group, and we'll see how we do. The first is, as I listen to this collection of papers and read them, I am sort of struck by the thought that maybe what we have is a situation where our goal should be, rather than maximizing or minimizing the use of telehealth, to just seek alignment between clinician preferences, patient preferences, and system capacity and preferences. Throughout all the presentations, regardless of modality we're talking about, it does seem like there's a concentrated group that's happy and that uses it. And then there are those who don't. So I just wonder if, as I say, whether the framing here should be alignment, and whether we should think about how to maximize people's ability to find, if they're a patient, to find a practice and a clinician who's aligned with their interest. Is that a useful frame? I'd be interested in anyone's reaction.
Well, I'll jump in first because I feel like you read my mind. I mean, I feel like that is at least the takeaway that I get from our data, which is that there is a small group that really finds it useful. And in a pandemic, it sure was handy, right? Like, let's not have all of this sort of go out the window and say, oh, where's telemedicine now? Like, in these moments, it's absolutely essential. And so it is to me about alignment, because as an everyday modality for every kind of care, it's not working at the moment the way people need it and want it to. But we can see where its inroads are. We see it in mental health, even in the context of primary care. So again, we asked about services provided by a primary care provider, and we know that mental health is a critical piece of that. that was more helpful, or more often helpful, or seen as high quality. We know it's helpful in the pandemic. We know it's helpful for some populations. And so I do think it's about alignment and about kind of finding the niche. That said, and here's the critical part, the policies have to then support it overall. Because even though it's just a niche, I think there's a risk that we don't have policies that support the larger infrastructure and systems that are needed. And so that's the tension that I see that's essential here.
Thank you. Other thoughts?
And I can talk a little bit about alignment from the provider perspective. So, we saw higher rates of telehealth uptake or provision by female physicians compared to their male counterparts. And so, we, although this is outside the direct scope of our study, we hypothesize that it's possible that female physicians may use telehealth at higher rates because they tend to have more familial responsibilities, and telehealth may allow them to juggle more personal and family responsibilities. So there's been some evidence that some proportion of female physicians after the pandemic are considering cutting back, and so telehealth may be a way in which that can be mitigated. And then the option to provide care via telehealth could also potentially delay physicians' decisions to retire. We also saw relatively high rates of telehealth among older physicians. So this may give them the flexibility to work remotely or to work in a hybrid way. So overall, for clinicians, telehealth may be a really valuable mode of care modality.
Let me turn to a very different question. Thank you for those reactions. They're very helpful. A lot of the questions that came in from the audience are sort of almost not questions. They're sort of, well, you're talking about this, but you're not talking about that. And I do wonder, given the presentation on remote patient monitoring, given the different ways that we're looking at different types of visits, whether, and hopefully this is a good last question to transition to the more policy-oriented panel. Are we sort of tripping up over our terminology here by even using terms like telehealth and telemedicine, when in fact we're describing a very broad range of functions, everything from synchronous visits, like the kind of conversation we're having now, to something like a wearable and the data being streamed in, and many things in between. So as I say, a lot of the questions were sort of, well, you found it about this, but you didn't find it about that. And I just wonder if we could spend a moment pondering whether we really have a clear sense of whether we have a single definition here of telehealth, or whether there are better ways to subdivide these functions so that we can, again, make a more hospitable policy and practice environment.
Though at least what I have in my mind is that telehealth is just the broader umbrella, which is that any use of technology to connect a clinician and a patient, and then telemedicine focuses largely on the video and audio synchronous visits. But I recognize that I myself included do not use these terms as precisely as we should, and so I appreciate the comments from the people in the audience just clarifying that terminology.
Thank you. Carter?
I completely agree with this point about the need for perhaps more precision in the language about different types of things. However, I do think that telemedicine, telehealth, these terms, the services that they encompass, there are a lot of trends and patterns that we see that I think can be found in research that focuses on remote patient monitoring, and also research that focuses on synchronous video visits, where certain patterns when it comes to substitution and complementary visits, for instance, are things that I think we tend to see across lots of these different modalities and are useful frames to carry across analyses of all of them. Yeah.
Yeah, I appreciate that comment, and at Teves as well. I think when you get into a policy discussion, people are saying, should we continue the rules about fill in the blank? They have a mental model of what it is that we're paying for, and it may or may not align with what's actually happening out there. And yet, Carter, as you noted, there are commonalities even across these very different domains that are also regarding patterns and access, that are also worth keeping an eye on. Nate, is that sorry, it's hard to see sometimes.
Yeah, I would also just add that if it's confusing for us, it's definitely confusing for patients too, and might also serve as a barrier to patients receiving these services. And Alan, to your point a moment ago about alignment and like connecting patients that are interested in receiving these with providers that are doing these services and doing a good job of it, that sort of ambiguity in language is going to be a barrier in terms of making that connection too.
Well, we have a lot more to cover in our event today, so I'm going to thank the panel for an excellent job of presenting some really good empirical foundation for the policies that we're going to focus on in the next panel. It's my pleasure to turn it over now to Atif Mehrotra at Brown University, who has been the advisor on the Practice of Medicine series for Health Affairs, and brings great depth on the topic, and also has been a huge assistance to us here at Health Affairs. So I want to thank you publicly. And with that, turn it to you to kick off the next panel.
Well, thanks so much, Alan. I have to say that really excited to host this next stage where these papers laid the foundation, and we're going to cover for the next 45 minutes the clinical and policy implications of this work, as well as the other work that has been published on this topic. And let's be clear, the timeliness of this webinar is unbelievable in the sense that, we're so focused on the election, but I think those who are really interested in using telehealth are really focused on another date, which is December 31st, which is it's been alluded to so many in the talks already today, but I think is front and center. When many of the flexibilities that we've described, and we'll get into some of those details in a moment, that have facilitate telehealth are expiring on December 31st. So folks are looking to our Congress, Medicare and Medicaid services, as well as the DEA about what's the future. And, the folks on the call here are on our panel here are just perfect situated as experts in this topic. And so I think they're going to provide a lot of insights on this topic. So we have three folks that are going to join us. Mei Kwong is from the Center for Connected Health Policy. Steve North is from the Center for Rural Health Innovation. And Allison Huffstetter is from the Robert Graham Center. And so I'm going to start the conversation with a couple of questions. And then I'm hopeful that we can turn to some of your questions. So just to echo what Alan said previously, please put in the Q&A tab as many questions you have that you'd like me to pose. And I apologize in advance if I can't get to all of them. So May, I'll start with you. I set it up. We have a lot of anxiety about what's going to happen at the end of the year. Through last winter, and I felt like early spring into the summer, there was a lot of momentum in the Congress that felt towards at least a 2-year extension of telehealth in the Medicare program. And then things have kind of shut down a little bit. For those in the audience right now that are wondering what's going to happen, I wonder if you can provide a little bit of the context on what maybe the holdup is and what your thoughts are about where we're headed next in the next couple of months.
Well, first off, thank you to Health Affairs for inviting me here today. What we may have slowed down, at least on the momentum that we saw earlier in the year about possibly extending some of the temporary telehealth waivers on the federal level, is that there's a lot going on politically on our landscape there. So I think that is partially responsible for some of the slowdown in the discussion, but that did not slow down the deadline. As everybody knows, December 31st, 2024, that's when all of these waivers that we temporarily have now on the federal level will end. Now, Atif, you mentioned this was like perfect timing for this webinar. Just last week, we saw a little bit of movement on the federal level. We saw the House Energy and Commerce Committee move forward a bill that would extend the waivers out 2 more years. Now, that's just one committee. As those who are familiar with the political process, the process of how legislation becomes law, gets passed and everything, that's just like the first step. There's still a long way to go, still needs to go through the House, then you have the Senate, then you got to have both houses agree, and then goes to the president. So that's still a long way up, but that was encouraging to see a little bit of movement forward. Where I think it will eventually go is like they will do something. It might be in a standalone bill, but I think probably what might happen is what has historically happened over the last few years is that they would put it into a larger bill, most likely an appropriations or a budget bill. Take some of that language from the bill that was moved forward in that Energy and Commerce Committee and put that language into that larger bill. So when they vote on the budget, which again is another sort of thing that's going on out there, they're in a continuing resolution era now. So they've got to do something with the budget. They'll probably all jam that into one big bill, pass that, and then there's an extension. Now, as far as what you mentioned, something else about the DEA, other extensions there, that was not included in the House bill. So the prescribing issue is a separate issue. But just also briefly, I want to also mention that we're talking about federal things and the federal deadlines. There's a lot of policy that goes on the state level as well. And that's been a little bit more predictable, a little bit more stable. And actually, a lot of those COVID temporary policies have been settled on the state level as well. So if you're concerned about Medicaid, commercial payers, that's been a little bit more of a settled environment.
Well, I appreciate you saying that, because I think so much of the focus is on the Medicare side, but there's a lot of aspects that are settled. And so it sounds like those of us anxious about this need to kind of just hold tight a little bit and hope by the end of the year something changes, though I wish it was earlier. But you mentioned the DEA. And so I wanted to turn to that next, and to Steve. There's been a lot of debate about the prescribing of controlled substances via telehealth. There's been some recent stuff in the news, which I hope you can allude to. Can you give us a little bit of, for those of you in the audience a little unfamiliar with this, can you provide a little bit of background about why there's this debate and, where things stand as of today?
Yeah, the debate is an interesting one, and it's grounded in the Ryan-Haidt Act of 2008. So we're looking at 16 years ago, a law that was, or a policy that was implemented when telehealth and telemedicine were in a very different place. And it was actually designed to target telephone prescribing of controlled substances across state lines or in sort of dubious circumstances. As we moved into the pandemic, and that said, you had to see a person one time in person to be able to prescribe controlled substances to them. I could do a newborn exam on a child in 2006 and see them 10 years later and prescribe ADHD meds via telehealth. It was very unclear. However, this was suspended during the pandemic, and it really opened up a lot of opportunities for people who did not have access to care, whether that be kids in rural schools and urban schools without child and adolescent psychiatrists, or people comfortable diagnosing ADHD, them receiving stimulants, or people struggling with substance use disorders, getting access to Suboxone and other life-saving medications. The challenge is that there have been some folks, some entities that have been bad actors in this more lenient space. People have been able to shorten the length of time it requires to do a comprehensive assessment and quickly prescribe medications. And unfortunately, that has reflected on all organizations across the country that have benefited from this waiver. And now we're putting millions of patients at risk of no longer having access to life-saving medication and care.
Do you want to mention quickly the leak that came out? I'm not sure if, there was also some legislation, or if I can summarize that too, just for the audience, but, or maybe you want to.
Well, one part of the leak, a few weeks ago, a leak came out from the White House that the DEA had a new proposal that was going to be quite restrictive. And it was that, so I'm a physician, I see patients in multiple states to prescribe Suboxone. And at least 50% of my prescriptions would need to be written in an in-person environment. And if I were prescribing via telehealth, I would need to check all 50 state PMPs, prescription drug monitoring programs, before I could write that prescription. And that is technically not feasible at this time. So that's what the leak indicated.
I mean, it's maybe building off May's comments too, there's a lot of uncertainty about where we're headed here. And I think there was also just in the last couple of days, legislation proposed, obviously not passed, to try to permanently address some of the issues. So we'll see what happens with that.
And the irony is that the Ryan-Haidt Act had very clear language saying the DEA needs to create telehealth prescribing licensure or guidelines, and that has yet to happen.
Yeah. Well, let me turn to Allison. And well, first just say, the DA, when they have discussed this, the regs, what are they worried about? They're obviously worried about abuse and the medications not going to this patient they were prescribed, and telehealth could facilitate that. And as Steve mentioned, there was a real focus on the telemedicine only companies. Well, telemedicine only companies are not just focused on prescribing for controlled substance. They treat a huge array of areas. And I've heard a lot of conversation from primary care clinicians and other clinicians about these telehealth only companies. I wonder if you can describe some of those concerns. And also, do you think we need some policy guardrails for telemedicine only care versus care provided by brick and mortar providers who are doing hybrid care?
Thanks, Atif. I think that that's a nuanced question that deserves a lot of consideration. And the word ambiguity came up in our conversations earlier, and that's a critical component of describing what's coming next for telehealth policy. And primary care, of course, is going to continue providing telehealth in these various modalities that we've discussed previously, whether it's reimbursed or not. And so the idea of figuring out what's the best component, what's the best modality for different types of prescribing and different types of visits is really key. And the panelists or the earlier discussants reviewed the types of care that can often be provided via telehealth. So the prescribing question is an interesting one. Of course, there is concern for diversion, for overprescribing of controlled substances. And without that in-person element, you can't have the accountability of some of the state mandated requirements, such as the urine screen, to ensure that the substance is in the individual system, things of that nature. Those are valid concerns. And with an opioid epidemic, we certainly have to take that into consideration. When I think through the elements that are provided and the care that's provided by a fully telehealth company versus that's provided in a primary care setting with a continuity clinician who knows you from when that clinician saw you as a newborn all the way through your high school and college experience, there's a different element of knowledge, trust, and appropriate accountability with those clinicians. And so when we're writing through the policies and thinking through what is going to be required for clinicians, I think it's really important to identify who is primary care, what does continuity look like in those circumstances, and what are the specific requirements for prescribing in those different types of specialty settings.
Great. And well, if I could just follow up, one of the pieces of legislation that has passed in the previously was specifically for mental health care. And there have been some requirements that that a mental health clinician in the Medicare program who must see the patient on some frequency for an in-person visit. And the assumption is that at least the policy rationale for that is that it's not good care if you're not getting some in-person care, and also some concerns about how this with primary care also. So I'm curious, do you think that those kinds of policies are a good one? Should we have some in-person requirements for all telehealth, or do you think that is unnecessary?
Oh my, I think that it's probably unnecessary in some circumstances. And there's a bill right now, the Telehealth Mental Health Care Access bill, that would remove that requirement within 6 months of having an in-person visit for mental health conditions. And what we saw from Carter's presentation, I believe, is that there are from Gianni's presentation, was that psychiatry is using these virtual visits on a very high frequency, at a very high frequency. And if this is done with a mental health clinician, perhaps that in-person component isn't necessary. I recognize the value of touch as a primary care clinician. People love for me to listen to their heart and lungs. It makes them feel better. But for some conditions like mental health disorders, perhaps that's not the appropriate venue and is not a good use of our resources.
I wanted to turn back to you, first, you had alluded to the fact that at the state level, there's a lot of things that are solid. So one of the questions here, and I'm going to do a call out to the Center for Connected Health Policy. Somebody said, is there a good resource to track state level telehealth policy? Go to the Center for Connected Health Policy. You'll see a lot of great resources about how to where legislation states is at the state level. So a call out for your organization may. But now turning to a question. Another policy issue is licensure and how this impacts the ability of a clinician to take care of a patient in another state via telehealth. I wonder if you could give a little bit of background on the policy and regulatory context of this and some of the reforms that are being pursued at the state level to try to address some of these barriers, and potentially some thoughts on where you think states are headed next.
So the biggest barrier, as probably most people know, is the licensure issue when you're talking about trying to provide services across state lines there. That was actually something that was in the forefront of a lot of telehealth folks' minds, a lot of practitioners and people in the telehealth community before the pandemic. But I think it really became an issue that was pushed to the forefront in policymakers' mind during the pandemic, because they actually experienced it themselves. I can't tell you so the Center for Connected Health Policy, we're a telehealth resource center. So we do technical assistance to basically anybody who calls us. And during the pandemic, I was getting calls from state policymakers, congressional makers saying, hey, my child came back from college and because of the pandemic, and they can't access student health because of licensure, because it was a different state. Is that true? And it's like, well, yeah, it is. So that came up as now a highly elevated issue in a lot of policymakers' sort of radar of like, this is a problem here. And it's really funny in that a moment ago, Allison talked about continuity of care, of like, not being able to engage with the patient that you've had this relationship with, that you've seen them in person. Actually, licensure kind of prevents that. If that patient is traveling to another state and then they want to or move to another state and they want to engage with a provider that they've had for years and years back in their old state. So since this issue was brought forward in the pandemic, really elevated, what we're starting to see now, sort of post-pandemic and even during the pandemic, are states. And if I wasn't clear, this is a state issue. The federal government doesn't really have any control over it. So it's each individual state deciding it. And pre-pandemic, for the most part, most states were saying, you got to be licensed if you're going to treat somebody within our borders. You got to be licensed by us. But what we're seeing now during the pandemic and then now post-pandemic are, at the very least, states starting to make exceptions. Even before, if you had that established patient-provider relationship and then you were temporarily in somebody's state, even if you're just there for vacation, or if you were just there for work for a few weeks, or if you were a college student, the law, the policy was you need to be licensed. You cannot see that patient via telehealth or, even in person if you happen to be there physically at the same time. You're starting to see states make those exceptions in their policies of saying well, if you've had an established patient-provider relationship before, you've already seen them in person, yeah, that's fine. Or they're starting to make exceptions of, well, you can see them if you're not doing this frequently in our state. If you do a couple of consultations a year or something. How you kind of regulate that? How do you know if it's only a couple of times a year? I'm not quite sure, but that's what's on their books. That's what's in their statute or in their regulations. Now, I mentioned that this was a state issue, that states decide what the policy would be. Two interesting developments have happened really within the last couple of months. In December of last year, there was a court case filed in the state of New Jersey saying that, these licensure laws around telehealth, they're unconstitutional based on arguments on the U.S. Constitution. And that's important, that it wasn't based on the New Jersey Constitution, the state constitution, it was based on the U.S. Constitution. Why that's important, though, is let's say the plaintiffs win this case and say, and it's judged yes, those were unconstitutional laws. That can reverberate throughout the nation there because it's based on a U.S. constitutional argument. A similar court case was filed in May of this year in California, basically stating the same thing. It's an unconstitutional, these licensure laws are unconstitutional. So that could also have an impact here on like what we see for the future of licensure and telehealth, but really licensure in general if you're talking about crossing state lines.
Well, great. Thank you very much for that policy context. Another area of uncertainty as we move forward here, but some traction at the state level. I wanted to turn to Allison, and then Steve, please feel free to jump in after Allison, on some of the questions that are being brought up in the Q&A have really focused on provider skill in providing telemedicine visits. And this kind of builds a little bit off Gianni's presentation, which is, there's a lot of variation on telemedicine use across clinicians. And at least in some of my work, we've heard clinicians who do this awfully well, and there's clinicians who are not so much, doing telemedicine visits, God forbid, in the car even, which seems inappropriate. And so, Allison, I'm curious what your thoughts are about how do we improve the quality of on the clinician side of providing telemedicine? Where are the holes in the training? And one of the questioners asked, is there a role of NCQA or some other organization accrediting a clinician saying that they've gone through sufficient training to provide telemedicine? What do you think of that as a potential idea?
Telehealth is a skill. I am a new mom to an 8-month-old. I see new milestones every day, and those are new skills that my child is taking with him to learn to be able to walk and chew at the same time. We are not imbued with these skills just as clinicians. We have to learn them just like we have to learn our milestones. And so I would say that the various types of telehealth require different types of qualifications. So is a primary care clinician reading someone's 30-day Holter monitor appropriate in all circumstances? Perhaps not. Is a primary care clinician calling a patient in the car on her way home to check in on a positive pregnancy test reasonable? Absolutely. And I would venture to say that most of us primary care clinicians make calls on our drive home because that's part of our job. And we don't bill for that. It's not part of what I would put in my chart, but it's something that absolutely counts as telehealth in a broad definition. So then what is the accountability? How do we educate, teach, and make sure that this skill set is maintained? Well, there are several studies that have been conducted, one most recently in JAMA Open in 22, that shows that quality metrics are maintained via telehealth for preventive medicine, for medication adherence, and for chronic care. There are inappropriate uses of telehealth, like an ear infection, the easy example of looking in somebody's ear canal we can't do virtually. But because we know those quality metrics are attained, perhaps that there is a training pathway for residents specifically that can show you're meeting this competency as a resident, and we are ensuring that as you graduate, when telehealth is now being used much more prominently, you are attaining those skills upon graduation from residency. And I think that would be the most likely avenue to ensure it. Now, that doesn't account for all of the practicing clinicians already, but I think we will see changes in continuing medical education on telehealth, and that's a big, important part of our continuing education moving forward. But I would be interested in what Steve has to say too for that.
So first, Allison, I want to point out one thing that you said about telemedicine, and I think it is that you can't see in the ear. And it's true that in a virtual visit where it's me from my house and the patient's at their home, I can't. But with peripherals, it is possible. And that's one of the things, thinking at a bigger policy level, that we need to keep in mind is, I've been helping lead a school-based telehealth program with peripherals for 14 years. And so we're able to do a different exam, and we don't want to see all telehealth get lumped together. But I agree there needs to be training and that there's a degree of showmanship involved, especially when you're seeing kids or people who are in distress. How do you see them and keep them engaged? Another really important part of the training is, and interstate licensure, is making sure that if I'm seeing a patient in Oklahoma, that if they're in distress, I know how to get to them resources quickly. How do I call mobile crisis? How do I connect them with domestic violence shelter? What are the options that I have so that I'm really at least connected to that community in some way? And too often I feel that that does not happen in virtual only care. And that is one of the great advantages of integrating care into the patient-centered medical home.
Well, Steve, I wanted to follow up with another question to you. This came up a little bit in some of the presentations, and this is about the rural-urban divide in telehealth. And some of the attendees have also asked questions about this. I'll frame it, I think, as one of the presenters did, which is prior to the pandemic, if we were to look where telehealth was being used, it was more likely in rural communities. So everyone thought this is going to be great. They have a head start. And yet consistently, we're seeing the opposite. Why? What's going on? And how do we fix this problem? Because we know that in rural communities, this is going to be so beneficial.
Yeah, as a storm just moved through, sitting here today in my town of 2,000 people, and I was pretty sure the power grid was going to off, but it did not. And I think that that is one barrier, is just broadband connectivity. In rural Appalachia, you can go down around the corner and drop your 5G down to 1 bar and no longer be able to connect. I believe that there are other factors involved as well. And some of them are on the provider side. There are already enough people coming to my office. Why do I need to make space for telehealth? Or we're so busy we can't think about how to integrate telehealth into care, especially smaller rural practices. We don't have big health systems to sort of lead that integration. But also there's the patient side. And being at home is convenient for many people, and it's great, but going to see the physician is also an activity. And it is, you go to town, and that may be driving a half mile or a half hour to come see me, and being able to have lunch with a friend. And so there's that aspect as well. But it is the broadband, it's the sort of the social connectedness, and also technical assistance for people. A big health system like Ochsner may have a help desk that somebody can call into, but our local clinic does not have that bandwidth in the practice to help somebody navigate their telehealth interface.
And Steve, if I just to follow up on what we can do to fix the problem, because I think the concern really is that if you talk to the average clinician, policymaker, patient, they're hopeful that the growth of telehealth would narrow this horrible divide we have in the rural-urban utilization. And yet with the greater use in urban areas, I think now there's a concern that it's actually going to widen that divide. Right. What if you were advising Congress, state legislatures, what would it be what would it take to try to go the opposite direction and actually use this as a way to reach these rural populations more effectively?
I think that moving to community access points at schools, volunteer fire departments, somewhere where there's somebody there to help initiate the visit, collect the vital signs, use any peripherals, that may increase uptake and help decrease that divide. It's been shown to help in a couple of situations, but other projects that I know of to use volunteer fire departments haven't worked well. Nobody came. I think that funding is always part of this, whether it be reimbursement or it be broadband infrastructure funding, or there's a current funding for telehealth infrastructure specifically for rural clinics. Those are all opportunities as well. But another part is, how do you find people who can be boots on the ground in practices in rural areas to advocate for its use and show how the practice in rural Nevada began using it to help using telehealth intermittently to see folks with type 2 diabetes, improve care, and transfer that knowledge to a practice in North Carolina or elsewhere.
Well, thanks, Steve. May, I wanted to turn to you next and ask a question about maybe getting into the weeds, but just such a critical issue in the debate about telehealth is, how much should telehealth be paid? And the issue specifically about parity. For those of you in the audience, just to clarify, there are a number of states have passed laws stating that a telehealth visit should be paid at the same rate or reimbursement as an in-person visit. Is that a good set of laws? I'll be, just to put out full disclosure, I've been advocating against those kinds of laws. I wonder if you can comment a little bit about the strengths and weaknesses of that type of legislation, and what you might think is going to happen in the Congress with in the Medicare program, at least.
So the laws that Ateev mentioned, those are actually for commercial payers. So they focus primarily, sometimes you may have Medicaid wrapped in there, but by default, the Medicaid program requires you to pay parity if you use telehealth. Otherwise, you would need to submit a state plan amendments. A lot of states really don't want to go through that bother, and like a reason on why you're not paying parity. And right now, Medicare pays parity as well too for telehealth delivery services. The one exceptions are federally qualified health centers and rural health clinics. They are not getting their usual rate. They get a calculated rate based upon the fee schedule. Although the bill that I mentioned about extending things did put some language in there saying that, starting January 1st, if that policy goes forward, they would get their rate. That's another discussion. The question was about like parity. Is it good or is it bad? And there are arguments for both sides. So for those, and Ateev, feel free to jump in and correct me, but for a lot of those who think that it may not be the best thing to pay parity for everything, or just in general for telehealth, is because there are such things as, well, you're using less resources, because maybe if you're doing a telehealth practice, you don't have those usual overheads that you see if you had like a brick and mortar location. There's questions about the quality. Is it a lesser quality if you're using telehealth, and maybe that should be paid less? There's a lot of discussion around that if you're using the telephone to deliver that services. Then you have the other end of, well, you are using the same skill set that you would have in person as you would via telehealth and delivering that. So why shouldn't a practitioner be paid the same? They're using their same experience, they're using their same skill set. Why is it paid less depending on like the modality used? Then there's also the fact that the cost may not actually be less if you're using telehealth. There's still the equipment cost, there's the extra time. Steve sort of alluded to this, and like where you may need to like work with the patient to get them comfortable on telehealth. There's actually, and CMS itself admitted of like, there may be some overhead costs that telehealth providers face when they're using telehealth to provide the services. So there's reason of like, paying like very equitable rates of what you would in person. And then I've heard this, and Steve might actually be a better person to talk about this, in that there could be a disincentive for or this impacts rural practitioners a lot more if they're not being paid a parity, because you could kind of in urban areas spread out your costs if you're getting a lower rate, just because you have like more access to more patients, whereas in rural areas you have more of a limited set of patients, and perhaps like you're not able then to extend those costs, so then you put rural areas at a disadvantage. I've heard pro parity folks also mention that as well. So I think there's legitimate reasons on both sides. Now the question is, going forward, what are we going to see? And at least definitely on the Medicare side, there has been also discussion about that, of like, oh, do we continue to pay parity around telehealth? I think if we get an extension, they'll leave it alone. Simply because I don't think they want to complicate matters much more as they like go through this. So if we get an extension, they'll probably leave it alone, but it's definitely like a discussion point on the table here of that. And I think if anything is going to get hit first of like, well, we'll pay you lower, it's probably going to be those audio only or telephone visits are the ones that are probably going to be kind of first up to be impacted by that parity decision.
Steve, you want to weigh in on the, thanks, May, that was great. Do you want to comment a little bit on the rural perspective?
Yeah, so may I agree that the issue of telephone only, probably that's a place that is not as technically difficult, and therefore less reimbursement is appropriate. But with rural providers, if you want to use telehealth to improve care of rural folks, you need to pay at an equal level, especially if it's integrated into a primary care or existing bricks and mortar practice, so that I may actually open up more space in my day by seeing people for brief telehealth visits through the course of the year in combination with in-person visits. The other aspect of this is, instead of saying we don't want to pay parity for telehealth, if we look more at bundle payments and at quality measures as ways to pay for healthcare, then the modality that I deliver that care by shouldn't really be up to the payer to decide. If I'm managing someone's A1C, if I'm keeping them out of the emergency room, and my quality measures across the board for the population I see are at or above the standard set, does it matter that 50% of my visits are telehealth? And should I get 50% less for those? I don't think that that's equitable, and I don't think it'll drive adoption.
Well, Steve, I think it's the issue of, there are a number of folks that have described how telehealth and the growth of telehealth is sort of goes along with payment reform, because it creates the need to have so many, giving the clinicians flexibility. Both you and May brought up a topic that I wanted to turn to Allison about, and others to weigh in also, which is the audio-only telemedicine visits. I'd like to joke that the phone call just got an amazing rebranding. It's called an audio-only telehealth visits. And, there's a lot of debate about this specific issue. Those arguing that this is really critical to increase access to care, but also worries that the quality is inferior, and we might have a two-tiered health system where the rich get the video calls and the poor get the phone calls. Allison, I'm curious what your thoughts are, both clinically taking care of patients as well as on the policy side. If you were advising Medicaid, Medicare, commercial payers, should they pay for audio-only telehealth visits? And maybe going to what Steve was alluding to, should they pay the same amount?
Sure. When there have been some surveys from the Larry A. Green Center looking at who is more likely to receive an audio call rather than a virtual visit with video components, we see Medicare uninsured, non-English speaking, and rural residents more likely to receive audio-only telehealth visits. Are those going to result in lower quality of care? We don't really have data to suggest one way or another on the audio only versus the video visits, because there are so many other confounding factors. But by reducing the ability for those individuals to be reached via an audio only call, I think we're actually going to perpetuate more of a problematic two-tiered system than allowing for clinicians to contact their patients in any way that they can. So for me in clinic, if it is easier for my 73-year-old patient to just call, for me to just call her, that is going to be a much more effective visit than her trying to figure out the camera for 30 minutes while I'm chatting with her and I'm looking at her ceiling fan. So provided that it is the appropriate patient, which in primary care, we really do know our patients, provided that, I think that audio only can be as valuable and has been shown to be used in a lot of those patient panels. Now, should they be used at the same rate, or reimbursed rather at the same rate? I would certainly argue that that is the case. I would also argue that we are in too much of a box of how we're defining telehealth, even in this conversation. Do text messages count? I text my teens a lot because that's how they love to communicate. Does that count for telehealth? Does that count for reimbursement? Is that different than audio only if it's text only? And how do we associate the changes in our forms of telehealth into the future? And this isn't a small, I'll be very brief about this, but this is not a small question, because when we put words on paper in the form of policies from Congress, they have to be interpreted by that agency into how the rulemaking and regulations are put on the books by CMS. And then commercial payers are, of course, going to follow what CMS puts on the books. With Chevron being overturned, deference has changed, and the way that we interpret ambiguity has changed. And so the words we use today to define telehealth will make a big difference down the road in how we interpret what should and shouldn't be reimbursed based on the changing landscape of telehealth.
There's so many questions I have here, but and a lot of great questions in the chat, but I'm looking at the time here. So I just had one more question, and it kind of builds a little bit off what Allison just said, which is looking a little bit to the future. One of the interesting things in the initial set of presentations was, if I could sort of oversimplify, we've seen two very competing trends in utilization. We've seen telehealth really fall off and maybe plateau from its big peak. These are the video visits and audio visits, to be a little bit more precise. And then the exact opposite with remote patient monitoring, where it's just really growing. And someone one of the audience members in the chat really alluded to the fact that the OIG has even expressed concerns of overuse of remote patient monitoring, or at least an audit risk. I'm curious whether, is this reflective of where telehealth is going? If we were to look 10 years from now, are we mostly going to be talking about this kind of asynchronous remote patient monitoring in primary care and cardiology and less about the video visits? Or I'm curious what your thoughts are. I know it's a hard question because none of us have crystal balls, but you guys are the experts. So I thought I'd at least get your initial reactions. No one's going to write this down, so we won't hold you to it. Maybe Steve, what are your thoughts?
So I hope that our discussion is moving towards remote patient monitoring and remote patient engagement, whether it be through self-check-ins and, digital apps, beyond just a conversation or a one-way sharing of information. So that's where I'd like to see this conversation move in 10 years.
I'll just choose randomly. Allison, what do you think? And I'll go to May.
I think we're going to see a lot of changes in the way that we communicate with patients. I like the word engagement that Steve used, because telehealth is a good way to get people engaged in their health. Primary care doesn't happen in my clinic. Primary care happens at home. And so I think the more that we can engage with the person at home, the better.
Right now, the policies aren't necessarily the best for increasing remote patient monitoring. So I think that would probably need to change for it to like really take off. But I was just interested in like listening to some of what Allison was talking about earlier. And I just wanted to point back to the first question Alan asked of the first panel. It's like really a lot of this is about alignment, in that, to align the policies in order to like really allow telehealth to grow really should be more about like, at least in CCHP's opinion, it's always been about, well, we should really leave it to the clinicians to decide how best to deliver care. Because, I'm not sitting there in the exam room with the clinician and the patient, and I'm also not a doctor. They are there with that particular patient at that particular time. And really, the decision should be left to them to decide how best to treat that patient via whatever means is at their disposal. And we shouldn't limit those needs in any way. Just let them decide on like how it's best to do that. So it's been like an interesting conversation to like hear about, all the various thoughts that we've had here. So I think until like these policies really align to like give that freedom and that decision making to the practitioner, then we're probably going to still see like just a little bit of slow growth as we go through this.
Yeah. Well, thank you. And I think that's echoed in some of the comments or questions I've seen from the audience members too, which is that a little bit of a frustration of some of the details. And if we move to a more bundled payment, partial cap model, we can give clinicians more flexibility on choosing the model that best suits their patients' needs. I wanted to thank all the audience members for their questions and apologize to those where I didn't get to their question. But I think it's been a great discussion. And thank you all to Steve, May, and Allison. And I think Alan might be having some technical issues. So, and it's actually a theme here. One of the things that has come up is that sometimes video visits just don't work. So I wanted to thank everyone for presenting their work and all their perspectives, and for everyone else who joined us in the audience. So we are adjourned.